I call to order the August 28th, 2026 meeting of the Health and Human Services Oversight Committee. Would the clerk please take attendance?
I note the attendance of Senators Prentice, Gray, Pearson, and Representatives Pearson, Lamontagne, Weber, Seacrest, and Mooney, and Representative Woods not being here. I'm assuming that Representative Lamontagne will act as a regular member. I am also adding in the presence of Senator Rochefort.
And Representative McDonald texted me this morning and a situation came up preventing him from coming, but he has an excused absence. Chair next recognizes Senator Gray for a motion on the approval of the minutes from the last meeting. Any second? Welcome to regular status. Any further discussion on the minutes? The minutes is so wonderfully done. All in favor?
Aye.
Opposed? A few things from the chair before we begin today. The first thing is about the Milbank Fellowship in Public Health. Each fall since 2021, the Milbank Foundation has awarded fellowships to approximately 24 people from across the country, people who work in the public sphere as legislators or officials within their state's Department of Health and Human Services. In the second cohort, that of 2022 to 3, Doctor of Public Health Marissa Henn, our Deputy Commissioner, and I were named as fellows, Milbank Fellows. In the third cohort, that of 2023 to 24, our Commissioner Lori Weaver was selected. And Madam Clerk, I will give you this script when I'm done, so you don't have to type it in if you don't wish to. In the fourth cohort of 2024-5, Associate Commissioner Patricia Tilley was chosen. In the fifth cohort, that of 2025-26, Dr. Jonathan Ballard, our Chief Medical Officer, and Dr. Trinidad Tellez, for 10 years, the Director of the Office of Health Equity at DHHS, now finishing her second term in the House, became fellows. And now just publicly named for the sixth cohort, that of 2026-7, are our own Senator David Rochefort and David Chorney, whom we will be meeting later this morning. So congratulations to the new fellows. Given the size of New Hampshire and the relatively small number of fellows, it is true to say that New Hampshire has a very disproportionate number of Milbank Fellows in public health. The new cohort will have several gatherings in person around the country, and those of us who are now alumni will be again offered monthly Zoom meetings, and we are invited annually to meet with members of the newest cohort. And this year it's at the end of November, early December in Miami. Now to the topic of fraud and waste. Attorney John Williams and I worked some months ahead on the schedule for our Oversight Committee meetings. Some of what goes on the agenda is because it's in statute requiring this or that organization to report to us in person, usually annually. On other occasions, the department wishes to make presentations to us of this or that. But additionally, there are what might be called hot button topics we need to be informed of because the public will be asking us if they haven't been already. When Attorney Williams suggested we hear about what the department is doing regarding fraud, an idea popped into my head. Why not take that topic and learn more fully and widely how fraud is being addressed, not just in the department, but at the state and federal levels? I first turned to the U.S. Attorney for the District of New Hampshire, Attorney Erin Cregan. Erin and I worked closely together for almost 2 years when I chaired the Special Committee on Family Court, and she was Chief Legal Counsel to the New Hampshire Judiciary. She informed me that her office is not allowed to testify in hearings, but there are good materials to be had describing heightened effort underway at the federal level. And we have some of those materials for the committee and maybe a few extra copies on the table. Additionally, I had a wonderful conversation with Assistant Attorney General Charles Buca, correct? Right? Close enough? Got it. And he will be making a presentation this morning. And then finally, we'll hear from our own fraud investigation people in the department. In talking with various people, I discovered two things. First, these people at each level are working very well together. I detected no turf battles or rivalries, but cooperation. Second, these people are highly capable and very dedicated. In her interview a few months ago with Channel 9, reporter Jackson Stover asked questions, and U.S. Attorney Cregan put it this way: "We have an excellent partnership with the state. New Hampshire's a terrible place to commit fraud. You are very, very likely to be detected. This is not a good place to be a fraudster." So with that, the chair would like to recognize some folks from DHHS who have a presentation to make to us.
Good morning. Good morning. I would, Chairman, hoping that you could also indulge me for the commissioner's update. We have the beautiful introduction that you made for fraud, waste, and abuse. I would also ask if you'd be willing to, after that presentation occurs, hear one other update that I have.
You are so indulged.
Okay, great. Thank you. So I won't, that was a great segue for Nathan and Meredith to come up and talk about that. And when they're done, if I can turn it back over, that'd be great. Thank you.
Good morning, Nathan White, Chief Financial Officer.
Good morning, Meredith Tellus, Director of the Division of Program Quality and Integrity. Okay, and I'll start leading you through the presentation. I think you all received the hard copy of the slide deck we're going to use. It looks like this.
If you could wait a few minutes, because we have an abundance of paper up
Sure.
here.
Yes, absolutely. I'll wait until I see some nods. It says
it looks
DHHS
like-
Program Integrity on the front.
Are there other copies over there?
Yes. Yes, there are.
Good, thank you.
You're
may continue.
welcome. So starting on what's labeled as page 2 of 21 is the agenda, and I'll just go through that very briefly. We're going to talk a little bit about provider and beneficiary fraud, waste, and abuse at the department. And then we'll talk about contract oversight, and then we'll talk about some of our internal controls. So going through page 3 to page 4, what is considered fraud, waste, and abuse? And the definitions that you have here, I won't go through them in too much detail, but these come from CMS. It's the most convenient method of us finding a definition, and they're meant to apply to Medicaid providers, but they can apply more broadly when you're thinking about fraud, waste, and abuse. So fraud is really an intentional act. Somebody knows that what they're doing is deceptive. They know that it's going to benefit them, usually make them or a family member money, and they do it on purpose. That's really fraud. Waste is what we consider sloppiness, right? So it's where someone is not necessarily intending to deceive, but they're making mistakes, they're not being careful, and as a result, we can make overpayments, and we don't want to make overpayments. Abuse is the thing kind of in the middle where it might not be an intentional act to deceive, but there could be a loophole that appears to be legal, it appears to be okay. It's probably not ethical, but there's something kind of happening in the middle there. And that still results in an overpayment, and we still want to detect that, we want to stop it, and we want to close those loopholes. So where payment is qualified as waste or abuse, providers will receive training and education. Where DHHS identifies gaps that can lead to abuse, we do clarify those rules and policy. We'll issue new regulations if we have to make clarifications. And we do have a note here, just because there can be some confusion around this. The SNAP payment error rate determines a number of cases with overpayments or underpayments to SNAP beneficiaries as a result of errors that take place during the eligibility determination process. It does not reflect fraud, waste, or abuse, just to be clear on that. And we have more information on that in one of the appendices that I can point you to later. So just to go over some of our partner agencies, Mr. Chairman, you had mentioned that we do work very well with our partner agencies. We have a number of partner agencies that we work very, very closely with. And on the left-hand side of this slide, for Medicaid providers, when we are looking at fraud, waste, and abuse, we work very closely with the people listed on this slide, one of whom will be speaking to you a little bit later this morning, and that's Mr. Buca. We also work with CMS, we work with the HHS OIG, and we work with our managed care organizations very closely to look at Medicaid provider fraud, waste, and abuse. Oh, I apologize. The Office of the Inspector General for the U.S. Department of Health and Human Services. I apologize. I should have spelled that out on the slide. Also, we have partners that we work closely with for beneficiary fraud, waste, and abuse. And those are listed on the right-hand side of the slide. And those are particularly our New Hampshire county attorneys who will prosecute member fraud when we identify it. We work closely with local and state law enforcement. We work with Food and Nutrition Agency. And we work with other partners like the Social Security Administration as well. So on the next page, page 6 now, there's a little more detail about how we get into Medicaid provider fraud, waste, and abuse. So the first step is either a specific referral or data analytics. So the first kind of column here goes over referral process, which is where an individual can be an employee at an agency. It can be a beneficiary or a family member of a beneficiary. Will make a referral and say, we think that there was fraud in this service or at this agency or for myself or for my family member. And we will actually go to that provider. We ask them for documentation. We do an investigation and we decide whether or not there was any fraud, waste, or abuse. The second way that we identify potential fraud, waste, and abuse is with data analytics. And we have some of that at the department, but we also rely heavily on our managed care organizations who do process the majority of billing for Medicaid. So they also have data analytics systems, and we will decide certain high-risk services that need to be looked into and run data analytics on those, and then pick out providers that appear to be problematic, and we'll do specific investigations on those providers. So post-investigations, we look at whether or not we see fraud in one bucket or waste or abuse in another bucket. If it's waste or abuse, we'll issue recovery letters to the provider, or our MCOs will issue recovery letters and we'll recover those funds. Or if we suspect that it's fraud, we'll work with our MFUCU, our Medicaid Fraud Control Unit, over at the AG's office and have the conversation about what our evidence is, and they will decide whether or not it's a fraud case that they're going to take on. And I'll just pause there and see if there are any questions about this.
Senator Gray.
There was a question, somebody in my office, we were talking about this issue about staffing and the ability, the staffing to go out and actually do some of these checks and different things. Can you comment on that, please?
Yeah, it's a great question. Obviously, if we have more resources, we have more ability to do these investigations. And we have been down staff. We were actually down, we had 7.5 positions in our Medicaid Program Integrity Unit, and only 3.5 of those positions are filled right now. Now, we did identify other resources within our division that we can move over to try to help beef it up, but I still have 3 vacant positions in that particular unit.
Are you allowed to fill them presently?
We would need to, well, we are seeking hiring waivers. We don't have an approved waiver at this time.
Thank you.
But it's it's important for us to have those positions because in
Mhm.
my conversation, no, he's going to back me up on this. In my conversations with Mr. Buka, the more robust investigation we can hand them, the easier it is for them to prosecute those cases for fraud.
So you are both searching for new people and in the process of asking for a waiver during a budget time when positions are generally left vacant.
That's correct.
Thank
We're
you.
seeking the position now, even before the budget. Yes.
Yes.
Any other questions? Senator Gray again. Yep.
Again, I want to emphasize this one because with the federal government looking at different fraud, especially in SNAP benefits and others, is that filling these positions is one of my priorities to make sure that we have a plan to go out and fill them because it can save me millions of dollars in other places keeping the rates down. So if there's anything my office can do, let me know because I'll be out there working for you.
Thank you, Senator. Appreciate that.
Anyone else with a question?
Okay. Slide 7, page 7, beneficiary fraud, waste, and abuse. We do have a special investigations unit. So the Medicaid Program Integrity Unit does the investigations for provider fraud, waste, and abuse. For beneficiary fraud, waste, and abuse, it's a different set of staff and individuals that work in our special investigations unit. And they're investigating referrals of potential beneficiary fraud or unintentional overpayments resulting from agency or client error. So that would be in the waste category. So where we accidentally created benefits that were higher than somebody should have received for SNAP, we will establish a claim and recoup those benefits from that person. Or where the person intentionally deceived us on their application, that's considered an intentional program violation. We will still establish a claim, but we will also create a case on that individual. And if we think we can prove fraud, we'll work with a county attorney to prosecute that case.
I have a question maybe at this point, if not defer it. The audits that you're doing are internal. Do you have external auditing?
We refer, I'm not sure what you think. Are you referring to FNS or FNA coming and auditing our process?
I am not sure what I'm referring to.
Okay, so we do, the way we do our beneficiary fraud, waste, and abuse, which just for 1 second, I'm going to flip to the next page. If you just look in the next page, you'll see a chart on the right-hand side, and it says TANF emergency assistance, childcare, cash assistance, medical assistance, SNAP. So we get referrals on all kinds of beneficiary assistance. I just wanted to point that out. We're federally required to investigate SNAP referrals for potential fraud. And that is the bulk of the referrals that we get. And we can get those referrals from all kinds of places. We get them from neighbors, from family members, from our own eligibility workers. They will say, we think that there's an issue with this case. We will get them what we call on the front end of an eligibility case. So where someone's just filling out their application. If a worker thinks, I don't really like the way this person answered this question and I'm suspicious, they'll make a referral then before the person is even open for benefits, and we will do an investigation. But we often get them well after someone's established for benefits as well. So we will do those investigations. And that involves, when you say external, I'm trying to think through what we can be referring to. That involves us going out into the community and interviewing the person, their family members, their neighbors, their roommates, whoever it is we need to talk to. We'll talk to their employers. We pull all kinds of stuff from the case files. We'll go and get their employment records, bank statements. Am I missing anything? All kinds of stuff. So it's an investigation that involves things that are in the case file, but it also involves us going external to get additional information.
I think the question that was submitted to me by one of our state representatives was, do you ever bring in an outside organization to take a look at what you're doing to see where improvements could be made possibly.
We do get audited by FNS. So they come and look at our process and determine whether or not we are doing it sufficiently and to their standards. We also work, I don't think this is what I think that's probably more what you were referring to, but we also do on our investigations partner with law enforcement or the Social Security Administration who are also doing investigations. We will coordinate with them to complete an investigation. And we'll also, if we find out that people are receiving benefits from other state agencies or other community partners, we will let them know that we're doing an investigation on someone because their benefits could also be compromised.
Representative Weber.
Thank you. I have one follow-up from what Representative Pearson asked. When he asked about an outside audit, I thought of an audit of the program generally. And do you do fiscal audits regularly of the programs just outside of a targeted fraud or waste investigation?
So our statewide single audit, which is done by KPMG and reported to the fiscal committee every year, does audits of all the major federal programs. And they do it on a risk basis. So like major programs that we're making a lot of money, like Medicaid's audited every year, they can't escape. Other programs that are past the audit may only be audited every 3 years, and then minor programs they select on a kind of case-by-case basis.
Thank you. That was helpful. And then my own question is, in the case of beneficiary fraud, have you done comparisons to compare what you have either recovered or saved as a result of whatever recovery, whether it's a letter, whether it's a prosecution, versus the costs of doing the letter or the prosecution? And whether, I'm just asking, is the game worth the candle, particularly with respect to beneficiaries, because it seems to me like there's a small amount of upside for a beneficiary, whereas proving that may be far more costly than what you're going to recover.
I completely understand the question. It is a very time-intense process to do these investigations. And the recoveries for beneficiaries are not always huge. We don't have a robust mechanism for gauging how much we spend per case. We were very lucky to be granted a substantial grant from FNS that is going to really help us with data analytics on our own cases, though. So we will be able to see within the next couple of years, I think it's a 3-year grant and we're at least a year into it, we will be able to see much more closely how much each investigator is spending time and what cases they're spending time on. So we definitely look forward to getting that information. In a general sense, though, you're correct in thinking that the amount that we're getting from beneficiaries per beneficiary, it may be a few $1,000s, it may be tens of thousands of dollars, but we're usually not going to recover it all at once. So it's usually something that's recovered month over month over month over the course of years. Yep, go ahead.
And Representative Weber, another thing to think about, though, is I don't necessarily think that you want to think about that function in terms of an equation of, is this worth the cost? Because there's obviously more of the intrinsic value of deterrence. And whether you view it as an internal control, it's very, very important that there is a functioning deterrent that exists. So I just want to emphasize the fact that this is not a function that can be simplified down to an equation of, is this worth the cost? Because what you're not seeing there is you're not seeing all the activities that may not have occurred as a result of the existence of that function. I just really want to highlight that.
Yeah, no, I entirely understand that and I appreciate it.
It is also federally required. So, On slide 7, for SNAP at least, it's federally required, and since we have the function, we do it for all beneficiary cases. On slide 7, we did make 8 referrals to county prosecutors in state fiscal year 2025. So those referrals are related to theft of benefits, referrals related to theft of benefits like identity fraud are referred to law enforcement. We don't do those investigations ourselves. We just report it to law enforcement.
Out of the 8 cases, how many were successful?
I don't know that those are even completed at this time. So sometimes these take quite a while to work through the system.
I know.
The next slide, page 8, has more statistics on it that we can run through. So in 2025, we received 1,447 referrals, the majority of which were SNAP. Of those, about 280 were over issuance due to error, and 364 resulted in an actual fraud investigation. From those, we ended up disqualifying 111 individuals from the STAP program and 27 from the TANF program. We did establish claims of $710,000 for SNAP, meaning that's the amount of overpayments that we established to try to recoup on. $200,000 for cash benefits and $35,000 for childcare overpayments. And we convicted, I do have the conviction, 3 individuals of welfare fraud, totaling $200,000 in SNAP, Medicaid, and childcare payments. That's the number as of today, but again, I'm not sure all those cases are finished. Moving forward, we're working on an analysis for out-of-state EBT use. We don't have a federal system that can tell us when someone is open for SNAP in multiple states. So I think they want that at the federal level. It's been talked about, at least at the federal or regional level, but it's not something that we have today. So we can't just go on and say, this person has benefits in Missouri. We're not going to open them in New Hampshire. So what we are working on for ourselves is just taking expenditure data and figuring out when the expenditures are happening out of state more often than they're happening in state, and then trying to parse that data down to a small enough number that it's worth doing an investigation on.
It may not be anything that you would know, but given the federal push on this, one would think there would be a national database where
Yes, absolutely. And I think that they are working. It's been part of the conversation for a long time, but it's not available to us today.
Representative Weber.
How do you determine, I live in a border town,
Mm-hmm.
and the Connecticut River Valley is very much one economic unit that is equally ignored by Montpelier and Concord in many cases. And so how do you deal with the fact that, in fact, we probably get more EBT business from Vermont because we've got the supermarket in Walpole and they don't. But there are other places up and down the river where the traffic is going in the other direction, and people are making purchases out of state because that's the closest place for them to make their purchases. How do you separate those out?
So right now, for the purpose of this report, which is relatively new, we're kind of experimenting with it to figure out. Again, we can't investigate like 400 more cases a month, right? So we have to really narrow it down. So right now, we're actually not including Vermont, Massachusetts, or Maine in the report. So we're looking at someone who's really making the majority of their purchases in Arkansas or something. It's like, well, what are you doing there? Then we need to look into that and just see. And it's legit. It could perfectly well be legitimate. Maybe they have a sick parent in Arkansas and they need to live there for 6 months, but we just need to figure out how many we can look at and whether or not it's legitimate.
Thank you. That's very helpful.
Okay, page 9. This is just background information on SNAP disqualification and how it works. So if we find a beneficiary has an intentional program violation, there are different terms of disqualification. If they have an IPV, in the first instance, they get a 1-year disqualification. The second instance is 2 years. The third one is permanent. If we find they're receiving benefits in 2 states, then they'd be disqualified for 10 years. They do not get removed. I just thought this was important information. They don't get removed for not paying a claim. So we have some beneficiaries that are not good at paying, or may pay less than what we had established for a payment plan, but that is not a reason for disqualification. Page 10 is related to childcare provider and beneficiary audits. So we do provider reviews. We do a monthly sample of providers to evaluate compliance with attendance and do they have required signatures, and we look at other records for that. In 2025, we reviewed 28 providers. We had 19 with findings, 16 providers with overpayments, and we recouped $18,000. We also do childcare subsidy audits. These are federally driven, and it's a pretty comprehensive audit that's done every 3 years. They evaluate eligibility and overpayment amounts. And our initial review was just completed for the federal fiscal year 2025. We had 276 sampled cases, identified 37 cases in error, and that meant a 4% improper payment amount. We do conduct interim reviews in the off years. So this is required every 3 years, but in the off years, we continue looking at it just so that we can try to catch errors that are systemic and fix them before we do the audit again.
Could I just, so, okay, so the 37% relate to the 276 audited?
Yes.
Okay.
Yep.
And could I ask, you say 276 were audited out of how many providers?
This is eligibility.
Okay.
So this is people that
So this is individuals?
This is individuals.
Gotcha.
Yeah, exactly.
And how many individuals are currently being served?
I
You
wish I
know
could
off the top
answer
of your
that,
head.
Representative.
Just order of
For
magnitude.
child care subsidy, order of magnitude, 5,300,
Okay.
rough
Yep. Okay.
estimate.
And just as a follow-up, were these cases picked randomly or because some kind of red flag went up?
No, these are random. This is
Okay.
a federally driven audit. We just have a sample size we have to pick from.
Senator Gray.
28 and 19, okay? That means that 60% or 66% of these cases that you've identified have got problems. That's, to me, is unacceptable. And so I want to know how we can, is that going back to the staff problem that I talked about before, or what is?
Probably not. Yeah, it's a fair question. So this is actually a little bit of a different area. And in this case, these are not necessarily fraudulent providers. This is probably a lot of missing signatures, missing documentation. So we want to find it. And as Nathan was indicating, we want to deter it. We want to teach them how to actually maintain documentation so that we can know whether or not what they're doing is simply a mistake, something that they didn't fill in, or is it a pattern of behavior that is happening on purpose and we are getting billed for children that aren't there on a regular basis or something like that. But the majority of what we're seeing here is probably providers who missed something. They just didn't comply with filling out enough documentation. And so the main product of this is that we work with the individuals in the program area who manage childcare subsidy, and we tell them what their providers are falling short on so that they can do more training and education of those providers.
So it sounds like classifying these 19 might help me in not being upset. How about that?
Yes, it's for these, it's more likely a matter of education.
Thank you.
Yep. Any other questions? Okay. Page 11. Oh, contract oversight. Let me give it to Nathan.
Thank you, Meredith. So Meredith talked about beneficiary fraud, waste, and abuse, and we're going to shift over to contract oversight. So if you take a look at page 12, so the department has about 845 active contracts as of today. And we have many different kinds of contracts, and some of those contracts are agreements whereby parties provide direct services to the department. And generally speaking, those are lower risk contracts because we know what services we're receiving. Is it an IT system? Is it an actuary? Are they looking at rates? Whatever it may be. And we know if those services are delivered. And then the other types of contracts that we have are what we refer to as subrecipient contracts. And that's where we contract with providers, nonprofits in the community, and they're providing services to clients on our behalf. And again, those are referred to as subrecipients. So that could be community mental health centers, regional public health networks, peer support agencies. These are just a few types of examples of those kind of agreements. And so with all of our agreements, when we set them up, we conduct risk assessments and we look at the deliverables, and we're very thoughtful about what we're putting in there before we sign on the dotted line and move those out. Once those are approved by GNC and they do become active, I think one important thing for this committee to understand is we generally never make any sort of payment until we either see a deliverable, we know the service has been delivered, we receive an invoice that provides us detailed information on how the time has been spent. Has the report been delivered? Many of our contracts are actually cost reimbursement, and what that basically does from the state's perspective is it shifts the financial risks over to the providers. They incur the costs, and then they must demonstrate to the state that those costs have indeed been incurred. We are, as part of our roadmap, working on making payment easier, and we're working on a couple of different pilot projects to try to expedite some of that so we can assess risk of those lower risk agencies and take the appropriate actions where we see fit. So on the slide in front of you here, I talked a little bit about subrecipients. We also have a financial compliance unit where we have a grants administrator that provides training both to internal and external stakeholders as far as how do you review the documentation that comes in. We do conduct on-site reviews of our subrecipient contracts where we look at the files, regular meetings with our contractors as well. And then we also conduct, ad hoc investigations as needed. And Meredith has some great people on her team that assist the program areas across the department with that work. If you turn to page 13, this is related to the subrecipients that I was referring to. So before we enter into a contract, we have a risk assessment process whereby we look at two major areas. One is we look at the programs and the operations. We look at, have you had significant change in your leadership? Have you implemented new IT systems? Have you ever ran this type of program before? All of those are risk factors that we need to take into consideration. And then we also look at the most recent 4 audited financial statements from that organization so that we can understand if they present some sort of solvency issue or liquidity issue, whatever it may be. Because if that's the case where we see there may be a red flag around the organization's financials, then what we do then is we mitigate that risk. And that's the next purple bar there in front of you. And to mitigate that risk, that's where we incorporate specific contractual remedies, deliverables, whatever provision may be appropriate for that circumstance into the contract. And then once that is active, that goes into that managed risk category there in front of you, where we go ahead and the program team and the financial team and some members of Meredith's team go out and ensure that those services are delivered. So again, when it comes to our contracts and the payments, there's a fine balance between making sure that you're providing proper oversight based on the risks that you see and ensuring that the services are delivered. Because for many of these subrecipients, they're providing critical services to the clients that the department serves, but they're providing it on our behalf. So that's the reason that we try to take a very thoughtful approach in assessing those risks and incorporating appropriate controls.
Are there penalties for providers who have repeated errors? And I don't mean fraud, but I mean, I've seen these forms, because of one of my day jobs, and it's easy to miss a line.
Mm-hmm.
But you shouldn't. And if there's somebody who's really just not getting it, Are there financial penalties? Are there removal of being approved? What is in place?
So I think it's important, for some, I think first it depends on the provider. And what's important is establishing long-term relationships with the providers and approaching it more from a partnership perspective if we're able to. I mean, I think that's the default where we have our people go out. If we see repeat errors, we will send people on site. They will have meetings. They will teach them how to submit an invoice. They will teach them what the report should be looking like. That by far and above is the preferred approach. There are very few contracts that have liquidated damages in them. Typically, that's in your much bigger contracts, like your managed care organization contracts, where the organizations are very sophisticated. But what you will not see in 95% of our contracts is a liquidated damages where we would assess penalties against the providers. That's generally not our approach because these are organizations that are providing services to New Hampshire citizens and our clients. And it's very important that we work towards success. I think success is, much more likely if you take a less punitive approach to that conversation, to have those relationships. I think it creates a more open conversation so that when we see issues, we have an opportunity to communicate to them, and they're open to receiving that so we can correct any issues that we do see and move forward.
Especially in a day when not every provider is willing to participate.
Precisely, yeah. So, I mean, they're generally working in good faith, and it's just a matter of really reaching out to them and helping them understand what it is we need to look at for oversight. The penalty they get is spending a lot more time with us in a lot more meetings and having a lot more conversations and emails go back and forth before they can receive payment.
Well, I can say I don't think my organization has been thus penalized by spending time with you.
Good to hear.
And that is all I have for the contract section, unless there's any further questions before we shift to internal controls.
Seeing none, carry on.
So internal controls, you can skip page 14, page 15. Some of our internal fraud mitigation tools. We have a prevention of fraudulent and unethical conduct policy. That policy has been established, I think, a long time ago. It was revamped maybe 6 years ago. It's actually been maybe less than that. It's actually been pulled out to be looked at again recently. It is part of the training that we have, the mandatory department-wide ethics training that we have. That's required every couple of years, and it includes the policy. We also have an ombudsman, and we have specifically a long-term care ombudsman and a general ombudsman, and they take internal and external referrals. And that's the end of our formal presentation. I can walk you through a few appendices that we attached, just so folks know what is in there and what those resources are.
Appendices are part of medical care.
we don't want to lose them.
Well, if they're hot.
Starting on page 18, this is just an outline of the current federal landscape on Medicaid provider program integrity. As I think a couple people have noted so far this morning, there is a heightened scrutiny at the federal level on program integrity, and this just lists out, tried to bring together into one bulleted list some of the major things that are happening right now in that federal landscape. So since May, the HHS Office of Inspector General has decertified or conditionally certified or suspended 10 state MFUCUs. This may be slightly outdated information, but it's only like a month or so old. Our MFUCU recertification that I'm sure Mr. Bucca will refer to is scheduled for October 1st. The CMS UPIC contractor, our Unified Program Integrity Contractors, currently conducting an audit of our MCO overpayment cases and fraud referrals. So it's another external audit that we're having of our Medicaid program integrity. We're doing a roundtable with CMS and other states in Boston in September, just a couple weeks away. There's a lot of increased congressional oversight. Both the oversight committees and CMS have sent letters to states asking for some very detailed information. New Hampshire has not received a letter like that yet, but I think about 15 other states have. CMS has also deferred Medicaid payments to both Minnesota and California, and I think New York might be on that list now too. And CMS issued an RFI for comprehensive regulations to uncover suspicious healthcare, which is called the CRUSH initiative. So a series of events. The next appendix on page 19 is really just going over our current Medicaid program and just a little bit more detail on some of the activities we're undergoing right now. We're looking specifically at ABA providers, home and community-based services, non-emergency transportation, and opioid treatment providers. And we're also engaged in a very large revalidation project at the direction of CMS, where we're taking all of our Medicaid providers, group Medicaid providers, with a prioritization on high-risk providers, and we're doing a revalidation in the next 2 years. Normally, revalidating all of our providers takes 5 years, but we're accelerating the process.
Mr. Chairman.
Representative Weber.
Could I have an example of what you're talking about when you're talking about a high-risk provider, just because we have so many different things we're talking about?
Yeah, absolutely. So CMS actually categorizes providers by risk level. And so some of the home and community-based care providers are considered high risk. Some of the substance use disorder providers are considered high risk. Durable medical equipment providers are considered high risk.
Thank you.
Yeah. Page 20, external audit remediation and follow-up. This just goes over some of the work that we have done to remediate findings from prior audits, both single audits, the federal single audit that takes place annually, and LBA audits, which are both financial and performance-based in nature. And those, kind of can pile up over years. And if you're not really dedicated to remediating findings, you can end up with more outstanding findings than you want. So we sort of set our sights on dealing with the single audit. In 2018, we had 50 prior year findings and 21 current year findings. And as of last year, we only had 7 prior year findings and 3 current year findings. So we really tried to reduce the scope of our outstanding findings. And 7 out of those 10 are actually the same exact findings. So once we get that thing fixed, we will have very, very few outstanding findings. Looking forward to that. We also reduced our outstanding LBA findings so that we could be in compliance with the executive order that requires us to remediate those and post them on Transparent New Hampshire.
The question is what do you need to fix it that we can provide?
What kind of resources? I really appreciate that, Senator. I think that for the outstanding single audit findings, I think that we actually know the path forward, and we very much anticipate, we know that the one finding that's hit us multiple times, we have a plan for it. It is related to our FFATA, which I don't know what that stands for. It has to do with federal reporting, federal expenditure reporting. We have a plan to fix it. Unfortunately, it will not be remediated in this audit because it takes time for it to work its way through the process. But in the next audit, it will be remediated by then.
So that's a question I should ask the ask me for money, right?
I mean, generally,
I would wave it at it.
The more resources we have, the better off we can establish our internal controls and keep our sights on protecting ourselves and mitigating risk. I think that is, oh no, there's one more page, one more appendix, and that is what I had promised you at the very beginning, which is more information on the SNAP payment error rate. So this just goes over what the payment error rate includes and is representative of, and what it doesn't measure and is not representative of. So it does measure over and under payments. It measures errors, whether they were caused by the agency when we made the eligibility determination or caused by the client because they didn't understand what we were asking. It's technical errors that happened when we were trying to calculate how much people should receive in benefits. It doesn't measure fraud. It doesn't measure whether or not we're denying applications or our timeliness, or whether or not we're notifying people correctly. or customer service quality.
Chair recognizes Senator Rochford.
Thank you, Mr. Chairman. So there was a lot here, and I didn't want to interrupt you, so I'm going to go back a couple things.
For sure.
But one thing I wanted to just dig in a little bit on, and you may have addressed this, and I just may have missed it, but that's particularly the CMOs that we're working with. And I think that you said there's currently a CMS directed audit of overpayment of our CMOs.
That might be yes. The UPIC?
UPIC,
UPIC
yes.
review? Yeah, okay.
So that obviously sounds like it's directed from CMS to do that. Does the department have an internal policy to audit our CMO or MCOs? Maybe I was saying CMO, but a lot of government letters jumping around here. So that sounds like a federally directed audit of our MCOs. Does the department have a policy internally where we're also auditing our MCOs?
We do. We do a specific, we look at our MCOs every way to Sunday, but we specifically have a program integrity audit that we do of them. I think, are we still doing it annually? Does Karen go out annually? Yeah, okay. Yeah, annually.
And that looks at all of those MCOs do a lot of things. So you're looking at all of the functions of.
We do a lot of functions. The one I'm referring to right now is specific to their program integrity work. So we go in and look at the way that they do program integrity investigations and data analytics, and whether or not they're meeting the terms of our contract for how they're supposed to do oversight of provider program integrity.
Okay. A couple follow-ups.
Follow up.
So do we know, obviously MCOs are doing the work, the private, similar to private payers that we look at. How does our audit process, where we're auditing our MCOs, compare with perhaps a private payer auditing their services, doing the same thing? I mean, are we auditing at the same level that a Cigna or United Health or whatnot would?
We look at the managed care organizations from a lot of different aspects. So the one I'm talking about right now is more about like their staffing, their process, and the way they do investigations and collect overpayments or make fraud referrals specific to provider program integrity. We also have what's called an external quality review organization, an EQRO, that's also federally required for us to have that. And they do all kinds of other audits of the managed care organizations. So they're looking at, for example, the encounter data that we get, the data of claims, and they're looking at whether or not that's accurate. And that's a very detailed technical audit. They're actually looking at whether or not every claim is processed accurately or not. So there's encounter data validation. We do performance measure validation. So the MCOs are supposed to report to us on certain performance metrics. Some of those are standardized. Some of them are things we, the state, developed because we want to know a specific thing about their performance. The EQRO does an audit of that to make sure that they are reporting on those metrics to our specifications, and they report to us on how well the MCOs are doing on that. They also do a report of quality. So they're doing like a specific quality study where we'll say, we want to know specifically how the MCO is doing on this aspect of quality that we told them to work on. And they'll go in and do a whole review of that and then give us a report on whether or not the quality is up to snuff. There are about 13 different specific reports that we get from that. There's provider satisfaction, client satisfaction surveys, secret shopper surveys. So there's a lot of different reviews that take place of the MCOs, and those are pretty highly technical reviews.
And I guess going back to we're trying to get at, I'm trying to get the question, maybe I'm not being clear on that, but how does that compare to a private payer? Are we looking at them to the same level a private payer would look at them, or are we on par with that?
You're thinking of the managed care organizations? Yes. And you're thinking whether or not a private
So
payer,
are we giving
like
the same, we as the state and the department, are we giving the same level of oversight to the providers to ensure that the claims are clean and being put in, properly, we're being properly as Cigna or United Health or Kaiser?
So you're thinking of the Medicaid providers,
yep,
as opposed to the managed
correct.
care organization.
Yeah, I'm getting down to the provider. Yep, I'm sorry, and that's probably my fault.
No, I was thinking of how we do oversight of our managed care organizations. When we, so the way that I think that so I'm going to be honest, I actually can't answer that question because I'm not familiar enough with the practices of private insurance. And I don't know exactly how they would oversee a provider compared to the way we oversee providers or the way our managed care organizations oversee providers. What I can say is that between our prior authorization process, so for services that are need some kind of prior authorization, we do that the same way that a private insurance does that. So a provider has to send us documentation and say, we want to provide this type of service to this person, and here's why. They have to actually demonstrate that it's medically necessary. So that kind of process happens the same way for us as it would for a private insurer. And then we audit claims. I would certainly assume private insurers audit claims a similar way. For many of our claims, when we review them, we have a system called Interqual, which is a software system that you can input the documentation notes and say, is the service that was provided medically necessary, basically. And that Interqual system is the same system that's used in many hospitals. It's very similar to that.
Great. Thank you. That's what I'm sorry it took me so long to
that's
get
okay.
there. Thank you.
Hopefully that helps.
Chair recognizes Representative Mooney.
Thank you, Mr. Chairman. Thank you very much for being here and all you do. Very thorough work. Slides 6 through 9. You focus on 2025 data. I'm just curious as to how that compares with previous years on par, higher, lower, that sort of thing. And it's funny about analyzing this data because the public could look at it two ways. Your numbers are high. The public could say, wow, we have a real problem. Or you could look at it as your procedures are so thorough, you're rooting out all of this fraud, waste, and abuse. Your numbers are low. People think, well, what are you doing up there? No procedures in place. Or you could look at it as, wow, we don't have a problem. So you're in that quagmire. So anyway, I guess my question is as to previous data before 2025 and how it compares. Thank you.
I'm going to say I think this data is pretty similar, but I just want to check with my backup here and see if she would agree or if it has any more detail. What do you think? On the SNAP beneficiary side. Yeah, member benefits. It's relatively steady. Yeah. Right. So that's a great point. So on the beneficiary fraud, waste, and abuse, which I think are the slides you're referring to, which is some of the 2025 data, that's pretty similar year to year. I mean, what's not on here is the total payments out the door. So we're not seeing this as a percentage, right? It's an absolute number. So you can look at $710,000 of claims and say, it's big, but is it big compared to the number of claims out the door? Probably not, right? There were 111 individuals disqualified from the SNAP program. There are 74,000 individuals on the SNAP program. So it's an extremely small percentage of individuals that have been referred to us, that we looked at closely, and that we said, this is problematic, and there's an intentional program violation here. So that's on that side. On the Medicaid provider side, just to refer to that for a minute, 10 years ago, yeah, I do not think we had the same amount of investigation. I don't think we had the same amount of investigatory capacity. We hadn't worked as closely with our MCOs. The MCO program was relatively new 10 years ago. So that really ramped up in the last 5 to 10 years, where we worked closely with our MCOs. We said, you are now processing the majority of our medical claims. You have got to beef up your investigations. You've got to use your data analytics. And we really leaned on them and pushed them to actually get in there and start doing strong investigations. And I think that amount has gone up. And I know that our Medicaid fraud control unit under certain attorneys has become more successful over time. And they have actually managed to really run prosecutions all the way to the end. And I think when we had started, myself and a few of my directors had started, we hadn't had a conviction in New Hampshire, and now we've had a number of convictions in New Hampshire for provider fraud.
Any further questions? Seeing none, Thank you so much for your presentation.
Thank you.
I'm going to go a little bit out of order here because of scheduling. First of all, Senator Rosenwald gives us her love. She has resigned from this committee and is not running again for the legislature, and we welcome Senator Prentice. Also, we have, I mentioned earlier, under Milbank Fellows, one is David Chorney, and if he could come up for about a 3 or 4 minute meet and greet. And if we like you, we'll invite you back.
Thank you. My name is David Chorney. I'm currently the Director of Financial Sustainability and Policy for the Governor's Office of New Opportunities and Rural Transformational Health, or Go North for short. It was exciting news to hear a couple weeks ago that I got accepted into the Milbank Fellows Program along with Senator Rochefort. So congratulations, Senator. I think it's a limited number of people that have gotten selected across the nation, and so I think it's really great New Hampshire's gotten to, and I think there's about 23 total. So it's exciting, and I really look forward for the opportunity. I guess a little bit of background about myself. I have a background as an attorney in health law, where I was in private practice in Massachusetts, and then the Office of General Counsel at Dartmouth Health, and then I transitioned over to the state to be the Deputy Medicaid Director, which was my introduction to state government work. And that was about 3 years ago. So working closely with Henry Lippman, the Medicaid director, on the managed care contracts, coverage models, ways to support the community mental health centers, and then partnered with the Division of Public Health and Medicaid, partnered to put forward the state's rural health transformation application it was about a year ago, shockingly, last year. And then the state was awarded the $204 million, which was the most out of any New England state, and transitioned into my current role over at Go North to help support the implementation and execution of the state's rural health transformation plan, predominantly focusing on how do we make these investments sustainable. So looking at different coverage models to support team-based primary care, mobile integrated health, how we reimburse hospitals, particularly our critical access hospitals, to maintain access to essential service lines, whether that be maternity care in the North Country, emergency services, behavioral health, and then support investments into the primary care space as well. So I think a lot of continued close partnership work with Medicaid, and then also the other commercial payers in the state too, to try to align, have multi-payer alignment with how we reimburse some of these services.
I have an is and a was in here, and
Yeah.
I want to make sure I get my tenses correct. You are the director of the Go North.
Oh, no, I'm not the director of Go North. The director of Go North is Donnelly Lozo. I'm
Yeah.
the director of financial sustainability and policy.
Financial
Yeah.
sustainability. Are you still working as an assistant to Mr. Lippman?
No, I'm no longer the deputy Medicaid director, but I was just sitting next to Mr. Lippman, and we talk daily.
We do too.
We collaborate often.
Thank you. Good to meet you.
Thank you.
And we'll be seeing you again, I'm sure.
Sounds great. Thank you.
Talk to my scheduler. And again, a little bit off, we've been off schedule somewhat, but the chair would like to call up Commissioner Laurie Weaver for the commissioner's report. Who's another jolly good fellow, by the way.
I don't know
See,
how
nobody can
jolly I
deny.
am this
Nobody
morning.
can deny.
So I'm just so mindful of the time. I think that was a great presentation, which is actually part of my update. And I actually have another group here to update on the long-term care eligibility process. However, I am mindful you have other agenda items. So if you think we should defer that for the next update, we can do that in September. Or if you want to try to squeeze it in, it's your call.
I'd like to go to the Senior Assistant Attorney General next because it's thematic.
Sure.
And depending on time and people's availability, either later this morning or in September.
Okay, great.
Okay,
Thank you.
Thank you.
And I will just let the chair know that the secretary needs to leave at 12.
I know. Thank you for the update, though. Now we recognize Senior Assistant Attorney General Charles Buca, who is going to talk about Medicaid fraud from the State Attorney General's office, who works closely with the department and does some work with the feds. Morning. The first duty of a testifying person here is, turn your mic on. Thank you. You know, I get so
In court,
self-righteous
they
about,
turn on automatically, and if you want to stop talking and be secretive, you have to press the button to turn it off.
I can press that button on you too.
Excellent.
But having
But
been
I think we're
self-righteous
done
on this, I went to testify somewhere else and I forgot to turn my mic on, so I understand now.
Thank you. Now that the microphone is on, Mr. Chairman, members of the committee, thank you for your interest in the New Hampshire MFUCA, or Medicaid Fraud Control Unit. May it please the committee, I'd like to introduce myself to you, provide you with some background about our unit and our mission. My name is Charles Buca, and I'm the director of the New Hampshire Medicaid Fraud Control Unit. I work within the New Hampshire Criminal Justice Bureau in the Office of the Attorney General at the pleasure of Attorney General John Formella. The Criminal Justice Bureau conducts investigations and initiates prosecutions in significant criminal cases within the state. Within the Criminal Justice Bureau itself, there are a number of dedicated prosecution bureaus or units which focus on specific areas of criminal activity within the state. There's the Homicide Unit, the Drug Prosecution Unit, Cold Case Unit, Public Integrity Unit, and of course the Medicaid Fraud Control Unit. The Medicaid Fraud Control Unit investigates and prosecutes fraud by healthcare providers who treat Medicaid beneficiaries within the state. A little bit about our unit itself. We have 3 full-time prosecutors, including myself, the unit director. We have 2 investigators and a financial analyst investigator. We have 1 paralegal and 1 administrative assistant position. As I indicated, I am the director of the unit, and my duties include the administrative matters associated with supervising the unit itself and their members, as well as prosecuting criminal cases from their initial investigatory stages through the completion of a jury trial if necessary. Generally, any appellate matters are delegated to the appeals unit within our office, and we enjoy the ability to collaborate with them on a regular basis during the course of litigation or case processing to seek their guidance and wisdom if and when we encounter complicated legal situations, which these days we tend to do more and more frequently. Very briefly about myself, I've been a criminal prosecutor for about 26 years. I spent the majority of my career prosecuting a wide variety of criminal cases in upstate New York. I came to the Attorney General's office after completing a 1-year term with the U.S. Attorney's Office in the Eastern District of Oklahoma. And I've been prosecuting criminal offenses on behalf of the Attorney General's office for approximately 4.5 years. The majority of my efforts were involved homicide cases, and in December of last year, I was commissioned as director of the Medicaid Fraud Control Unit. As I indicated a few moments ago, the MFUCA investigates and prosecutes fraud by healthcare providers who treat beneficiaries within the state. Healthcare providers include, but are not limited to, hospitals, nursing homes, doctors, dentists, pharmacies, ambulance companies, or anyone else who's paid to provide healthcare services to Medicaid beneficiaries. The unit also investigates and prosecutes cases of harm to residents of healthcare facilities that's caused by abuse, neglect, or financial exploitation. The unit receives 75% of its funding from the U.S. Department of Health and Human Services under a grant. The remaining 25% is funded by the state of New Hampshire. What we do is locate and prosecute Medicaid fraud. And Medicaid fraud has several different varieties with which we see and are charged with prosecuting. There's Medicaid fraud itself. There's, as I indicated, resident abuse and neglect, and also something called drug diversion. And I'd like to just spend a few minutes talking about each of those various areas with which we exert our prosecutorial efforts. With respect to Medicaid fraud itself, there are a number of different areas and common crimes or schemes which we see and we prosecute. I'll give you some examples of those. There's something called billing for services not rendered. It's a relatively common theme that we see, and that's where a provider would bill Medicaid for a procedure or a service that was not actually provided. There are, again, very frequently we see billing for upcoded services, and that's where a provider would misrepresent either a medical diagnosis and symptoms on a patient record, or simply select a higher paying procedure code to obtain a greater reimbursement than they're authorized to or allowed to under the program. We also see billing for uncovered services, where a provider would bill Medicaid for a service that requires use of a licensed or certified professional and uses unqualified staff. We see drug substitution. We see kickbacks, supplemental charges, where a provider would charge a Medicaid recipient for a service which is covered by Medicaid and should be billed to Medicaid, but then they charge the recipient the difference between the provider's usual fee and what Medicaid pays. And we also see inflating the usual and customary charges, where a provider would charge Medicaid more than their usual and customary charge for the same product or service billed to other insurers and the public. A provider might inflate the cost of the procedure, services, or goods provided. The second area which I'd indicate that we prosecute on a regular basis is resident abuse, neglect, and financial exploitation. Resident abuse or neglect is any action or a failure to act which causes unjustifiable harm to a healthcare facility resident. It usually includes physically assaulting a resident. It could be also be withholding necessary food, care, or medical treatment that they're entitled to. The unit investigates reports of abuse and neglect in any inpatient or residential healthcare setting, including hospitals, nursing homes, or assisted living facilities. Resident financial exploitation is the illegal or, yes, sir.
Representative Weber.
May I just ask whether these are prosecutions that are solely Medicaid patients, or do you prosecute with respect to patients who are private pay as well?
Mostly Medicaid patients. If the facility itself is Medicaid funded, then we would have the jurisdiction and authorization to prosecute those. And just finishing that particular area, resident financial exploitation would be the illegal or improper use of funds or assets of a healthcare facility resident, and would include misuse of their personal funds held at the facility, and may also include the misuse of funds by a resident's designated financial agent. Drug diversion is another area with which MFUCU has a specific jurisdiction, and drug diversions occur in hospitals, nursing homes, and other residential facilities. Diversion is the unauthorized possession of controlled drugs, which would include obtaining the drug, retaining the drug, or administering a controlled drug. Drug diversion can put patients or residents at risk, and it consumes valuable medical and financial resources. Some examples of drug diversion would be the unauthorized administration of medication, unauthorized substitution of medication, failing to fully dispose of any excess medication, or pretending to dispose of medication using another substance like saline, withdrawing excess medication from a dispenser or a medication cart and failing to dispose of it properly, or documenting that a patient received medication when in fact they did not. And it would also include suspected impairment on the job due to unauthorized personal consumption of medication by an employee. Our unit is currently investigating or prosecuting cases of each type just discussed. I'll discuss here in very, very broad and general terms some of those current cases so that I can make sure that I adhere to prosecutorial ethical rules and not discussing specific cases and their facts in a public forum. But with regard to Medicaid fraud itself, we have two recent investigations regarding healthcare providers billing for services not rendered, and those cases have recently been presented to grand juries, both of which have resulted in true bills or indictments being returned by the grand jury, which of course results in a formal charge being filed in Superior Court. With respect to resident abuse, neglect, and financial exploitation, we have several current investigations where we're reviewing potential criminal offenses. Those are underway and include both resident abuse and neglect as well as financial exploitation, separate cases, but we've seen both types recently. With respect to drug diversion, we have a current criminal prosecution and continuing investigation regarding a drug diversion or diversions resulting from nursing homes where a staff member was stealing a resident's prescription medications and attempting to hide the theft by replacing the prescription medication pills with other pills that were not prescribed by the patient. And so while we would like to think that someday all of our prosecutorial efforts will prevent Medicaid fraud from occurring, that's not realistic. Our mission, therefore, is to identify any potential Medicaid fraud which is occurring, investigate such matters, and if Medicaid fraud is confirmed, then prosecute the cases. As we've just discussed, we currently have investigations and in some cases active criminal prosecutions in each of the categories with which we're charged to prosecute. I can tell you that the New Hampshire Medicaid Fraud Control Unit works collaboratively with our federal partners in our continuing efforts to combat medical fraud. My unit has historically worked with the New Hampshire U.S. Attorney's Office, the FBI, the Office of the Inspector General, and other federal agencies. We've recently been contacted by a couple of federal agencies and offered assistance in the form of investigative resources, specifically in this example with the collection and review of voluminous digital evidence, which would be labor intensive for a unit our size to do, but the federal agencies have offered us that assistance, which we're happy to accept, and we anticipate working collaboratively with them and thanking them for their efforts. As an example, later this afternoon, I have a phone call with my unit scheduled with an assistant United States attorney here in New Hampshire. We have contacted them and would like to discuss a potential case which we may refer to them for investigation and prosecution. So I would say that we work collaboratively with as many federal partners and enjoy and accept help and resources whenever they're offered in any way that we can. I can tell you that recently both my unit and the New Hampshire U.S. Attorney's Office have participated in the 2026 National Healthcare Takedown. This is an effort spearheaded by Vice President Vance and HHS Secretary Kennedy. It's been an area of prominence on the news recently. You may have watched the press release. I've read that this 2026 National Healthcare Takedown, which was announced on June 23rd of this year, was the largest coordinated federal and state health care fraud enforcement in U.S. history. It involved 455 defendants across 56 federal districts and 45 U.S. states and territories. And some of the materials that I've provided with you, I've handed out a copy of the national press release itself as it relates to this National Healthcare Fraud Takedown. And there's just a couple pages there just to give you an idea of the scope of it. And I've also included several pages in there. I didn't print the entirety of all of it, but I've included a couple of pages of the press releases which reflect the participation from my unit in this, as well as the New Hampshire U.S. Attorney's Office. If you wish to take the time to review those, you'll see that we included a case in this federal effort, and the U.S. Attorney's Office included 4 cases. So very briefly, I've also given you another handout, which is a flow chart, and that's kind of what the Mafuku process is, and I'd like to just talk to you about that a little bit. I know you've had some information this morning already regarding the process with which investigations would come to the Mafuku, and I just wanted to kind of walk you through that very briefly if I could. As we discussed, the vast majority of our investigations come to us from referrals, and referrals come to us through several different mechanisms. There is the Department of Health and Human Services Program Integrity Unit, which we've heard some testimony about earlier today, and that's located within the Division of Program Integrity at the New Hampshire Department of Health and Human Services. It's designed to detect and prevent fraud, waste, and abuse within the state Medicaid system. It does this through frequent audits and reviews of Medicaid-funded programs, through information received from the state's contracted managed care organizations, or MCOs, as well as other sources. The PIU also works with other New Hampshire DHHS units and bureaus, such as the Bureau of Facilities Licensing and Certification, to identify potential problems in care facilities. And when the PIU finds a credible allegation of fraud, as distinguished from waste and abuse, the fraud allegations are then forwarded to my unit, to the Medicaid Fraud Control Unit, and then we conduct an investigation. We also receive referrals from the managed care organizations themselves. Those are private entities contracted with the state of New Hampshire Department of Health and Human Services to help administer the Medicaid program. Each of the MCOs has their own special investigations unit within it, which is responsible for detecting potential fraud, waste, and abuse related to Medicaid clients enrolled in their plans. And I think you've heard some information about this earlier, but the MCOs, of course, have their own computer systems they utilize to help them search for and identify potential instances of fraud, waste, and abuse within their plans. When an MCO does detect a potential fraud, they're required to report it to the PIU, which is then required to forward it to the MFUCU if, upon review, they determine that there's a credible allegation of fraud. When an MCO detects a possible instance of fraud but not enough to report, they can submit a request to open an investigation to the PIU, and MFUCU is notified of these requests, and we have the ability to review them and intervene if we choose to do so. We would intervene if we had a current open investigation into that same provider and that they were looking at, or if we determined there was enough information there to conduct an investigation ourselves. We also review and obtain information from what we call key TAMs, or whistleblowers. And a key TAM is a case where an individual known as a relator has personal knowledge of Medicaid fraud within a specific institution. The relator then would file a suit through counsel on behalf of the state or a collection of states. And if the suit is successful, the relator would receive a portion of a settlement, which is their incentive to bring these matters forward. In New Hampshire, only if the defendant has its principal place of business in New Hampshire, or if the defendant received reimbursement from the state's Medicaid program equal to a certain portion of its total state Medicaid assistance reimbursements within 12 months, would they have the ability to do that. We also receive information from NAMFUCU, which is the National Association of Medicaid Fraud Control Units. And aside from helping coordinate large key TAM cases across multiple states, NAMFUCU also helps coordinate other regional or national level cases that don't fall within that category. The NAMFUCU will participate in those additional cases as well. We, of course, are always hopeful and occasionally do receive referrals or information from citizen complaints. And we can do that through phone lines, which come directly to our office, or through an email tip line. We also receive information from medical providers themselves. And an example would be if a home health care provider made a referral, they would make a referral if they discovered one of their home health aides was billing them for services that had not been rendered. We receive information and referrals from the Bureau of Adult and Aging Services, and the MFUCU receives a copy of every law enforcement referral that Bureau sends out, and it gives us the option of interceding should we review that and find one that fits within our particularized Medicaid function or areas. There are other law enforcement referrals. Occasionally we'll receive a referral from a police department that has discovered something that they believe might fall within a Medicaid fraud area of prosecution. Just as an example, we recently had a matter where a local police department made an arrest. The arrest occurred at a nursing facility where there was an alleged drug diversion occurring and impairment on the job. They did not contact us directly, but not intentionally, but they just didn't realize that that was an area that we would be interested in reviewing and potentially taking the case. We've learned of that and then are working collaboratively now with them to assist in the prosecution of that case. We also receive federal agency referrals from the Office of the Inspector General, or our local United States Attorney's Office. And as I indicated, we are working collaboratively with them, and we're in fact potentially referring a case to them maybe as early as this afternoon. Once received, the Medicaid Fraud Control Unit will review each of these complaints or referrals to determine if it meets the specific requirements of our federal funding sources. So that would be that it has to involve a Medicaid program, it has to involve a Medicaid provider, and that it takes place within a setting in which we have jurisdiction, such as a Medicaid-funded residential facility for certain types of crimes like drug diversion or abuse, neglect, and exploitation. We have the ability to review these matters, and we can either accept them or decline them. If we decline a case, that's not necessarily the end of the matter. We'll then forward the matter to an appropriate entity with jurisdiction. In most instances, that would be the Program Integrity Unit, and they would then be able to take administrative action and seek financial recoupment from the provider. If the Medicaid Fraud Control Unit does accept the case, then the unit will conduct our own internal investigation, and that's what our investigators are for. An investigator will be assigned. They'll continue the investigation as it has been sent to us. If there's sufficient grounds for us to charge an individual or a company, we'll either bring a criminal charge or a civil case. Criminal charges can result in fines, recovered funds, and or incarceration of an individual. Charging criminally, of course, carries a much higher burden, and that is proof beyond a reasonable doubt than a civil matter. Civil matters can result in recovered funds and financial damages to an individual or corporation, but of course not incarceration. And civil matters have a lower burden of proof, and that is, of course, beyond a preponderance of the evidence. If there are not sufficient grounds for us to charge an individual or company, we can either forward it to the PIU or another organization who might be able to take action. As I indicated earlier, with regard to our unit, when we're fully staffed, we have 3 prosecutors, including myself, the director. We have 2 investigators, 1 financial analyst, a paralegal, and an administrative assistant. Currently, we have a vacancy in our administrative assistant position and in one of our prosecutor positions. So we're actively seeking employees to fill those positions. We have recently hired another prosecuting attorney who I would describe as a career prosecutor. In addition to other matters, she has a background in prosecuting large-scale health fraud matters with the U.S. Attorney's Office, where she worked for approximately 9 years. And it's my understanding that the committee was interested in hearing from us to provide you with some information about who we are and what we do and what we're currently doing to address Medicaid fraud within the state. Hopefully, I've provided you with that information today. I'd like to thank you for the opportunity to address you, and I'd be happy to try to answer questions, time permitting, if anyone has any.
Any questions? Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. I just wanted to dig a little deeper into the issue of abuse and neglect of elders in institutional settings, or presumably in home care settings as well, if they're receiving Medicaid benefits. Would that be correct?
Absolutely.
And so if they're in an institutional setting and they're not receiving Medicaid benefits, you could investigate under the broad authority because of the institution's certification. But am I right in thinking your unit would not prosecute that abuse case? You would refer it to a county attorney, or where would you refer that?
That's a pretty technical question, and I'll answer this with the caveat that I'm relatively new to the unit. But my understanding is, and I haven't had a case specifically like this yet, but if the facility itself is a Medicaid-funded facility, so if they're receiving Medicaid funding, and there is a case of abuse, neglect, or financial exploitation within that facility, we would have the jurisdiction to take that case and investigate it. If for some reason we ran into an issue where we did not think that we were the best prosecutorial unit to do that, we would, of course, reach out to another agency to take that case, such as the local county attorney's office, or depending upon the scale of it, whether it's something that's localized to that particular location or whether it's something more widespread across multiple such locations, potentially a federal referral to the U.S. Attorney's Office.
Okay, thank you.
Any further questions? Seeing none, thank you so much.
You're
Really
welcome.
enjoyed this presentation, and be safe in your commute back to your office.
The elevators can be tricky. Thank you.
For our next presentation, something I am considering going forward with regarding fraud. After veto day, I happened to be among several legislators at the outdoor patio of Tandy's. The subject of fraud and waste and corruption came up. Somebody suggested a bill be filed to raise up a study committee to work alongside what DHHS is doing. Nobody present suggested that DHHS doesn't know what it's doing. The suggestion was for an extra set of eyes, outside eyes, to assist. There were no snide remarks or anything about DHHS, which, considering this was a group of legislators, I found this quite extraordinary. Somebody pointed out, however, that even if a bill were successful, it would take a year or more for such a committee to be activated. Somebody there said, why doesn't the chairman of DHHS Oversight do something about it? And said, who is that? And after the laughter died down, I said, yes, I will consider this. This week, I have discussed this possibility with the governor, the commissioner, my ranking member, and for protocol purposes, the clerk of the House. I want to take a week or two to think more about this possible subcommittee, receive input in terms of what and how the subcommittee might be of help and who might serve on it. Actual members per se must be members of this oversight committee, but I can ask other members to join in because we're not really so much going to vote as we are going to investigate and discuss and help and make suggestions and so on. So other members certainly can join in if they're willing to work hard. I suspect we'll do some intensive work probably after the September primaries and running up until November at some point. So your suggestions and your volunteering of names or somebody else's name are all quite welcome. With that, Commissioner?
Could I have a
Yes.
clarification? My understanding, and correct me if I'm wrong, is that the chair must be a member of this body, that the other members of a subcommittee created by this body may be other members either of the legislature or members of the general public. Am I wrong about that?
This is not consistent with what the clerk of the House told me yesterday,
Okay.
but for practical purposes, the kind of work we're doing makes it somewhat irrelevant whether other people on the committee besides the chairman are actual members of this committee or not, or even members of the
I thought we
legislature.
had private persons as members of subcommittees in the past, which is why I asked. You may
Effect-
not want that going
Effectually,
forward.
it will be that, but
Okay.
not as, quote, voting members, unquote, according to the clerk. Commissioner. Fellow.
It's like my third time up here and I really haven't said anything yet. Have you made a decision? Would you like to hear the update?
I would love to.
Okay, I have to bring more people up, so I just don't know what time this meeting officially ends.
When we get hungry, it's okay.
Okay, I'm mindful of some folks that need to leave. I will introduce the folks that are going to come up and give you the update. But this is really a good news update, and I think it's important to share and go into some level of detail while being mindful of how much time we have. But we do have a packet, I believe, that you have with you that we'll go over. But as you all probably recall, long-term care eligibility and some of the internal processes that we have had historically in the department, not just within the last couple of years, but for decades, the decades that I've been with the department, it's been really challenging. And so last year, in conjunction working with the Health Association, the department, the legislature, we were able to get an appropriation for a contract to be able to have somebody come in and help us process pending applications, as well as having staff in nursing facilities to be able to help move that process with families. So if it was missing documentation, if it was whatever the communication and closing that gap. So I'm just going to give you the high level. I get to do the Cliff Note version, being the commissioner of the good news. I'll give you the stat that are basically we've seen when we think about the applications that have been pending more than 120 days. That's the amount of time that we have given to us by the feds to get these applications processed. So technically, we're not out of compliance, but 120 days is a long time for somebody to wait, and we recognize that. Our total pending applications have seen a 24% reduction within the last year since we've got this help. Overall, actually a 47%, a 47% decline in apps that are pending more than 120 days. So almost 50%. That we have been able to decrease that. But our total pending applications, all of the ones that come in, which means ones that we're trying to address and resolve, as well as new ones coming in, we've seen a 24% reduction. So how all of that has played out, I've asked Chris Santinello and Melissa Hardy to come and share some detailed information. But the good news is that the resource that you gave us is working. The system is working and we're seeing progress, and we'll continue to move forward with that. So we have to look at what processes did we have, what resources did we have to keep that success, and how do we keep perpetuating that moving forward so that we have more timely eligibility determinations. So that's my Cliff Note version, and I turn it over to Associate Commissioner Christine Santinello and Melissa Hardy, Director of Long-Term Care Support Services.
Good morning. So thank you for having us. There's a robust deck. We're not going to go over everything. The commissioner did give some highlights. We are also joined by Dave Hobson, who is our Director of Project Management here at the department. And I think, like the commissioner said, we knew this was a problem, and we knew we had to make swift action. And I think what's really important is that we came together. Eligibility, long-term supports and services, Medicaid, Commissioner's Office, we all rallied and said, how do we fix this? And we spent a lot of time working with staff and hearing from staff, what do we need to do better? We actually had a session, and it's kind of funny because we were like, okay, if you were commissioner, what would you change, right? And they had a lot of really practical things that we said, okay, this makes sense. And so we developed a plan. We took about 4 months, I think. We shadowed staff. We did a lot of work with stakeholders. But what we wanted to do is we wanted to fix the core problem. And so we're going to talk a little bit here about what we really did. But I think it's really important for us to share that, one of our biggest issues was incomplete applications. You can submit a Medicaid application with putting your name on the top and signing it. That's an application, but that doesn't give our staff the ability to process an application. And long-term care is super complicated. And I think we really worked with our staff to change the culture and their mindset. Instead of what's wrong with this application, how can we help this person to become eligible? And what we found is that we did not have clear guidance for our staff. We did not have a lot of written protocols. So how do you then help a family get equipped to apply for Medicaid? And I think, oftentimes it's a son or daughter who may not be living with a parent, and they may not have all of the information. And so we really identified what are the problems, and then what do we want the future state to look at. So we've spent a lot of time, and in your slide deck, you're going to see we get over for calendar year 2025, we had over 7,800 applications received just for long-term care. We actually, and on top of that, we are required to redetermine eligibility every year for financial and medical, and that's another 7,300. So there's a lot of volume happening, and it's very complicated.
Okay.
Good morning. I'm Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. You're fine. Yeah. As Chris said, on slide 5, just kind of giving you a broad overview of who the team is that is actively working on this roadmap project. So we have a core work group that Dave leads for the department that has line staff, supervisor staff, both from the Bureau of Family Assistance, our Medicaid department, and our long-term care department. We have executive leadership. We have outside providers, our aging and disability resource centers, or formerly known as Service Link partners. And we also partnered with UNH and the Center for Healthcare Strategies as part of our group.
Are we supposed to try to take all these names and match?
Yes, who's
what
who?
are-
It's like guess who. Yeah.
Okay, I got some of them.
Yeah. So we just wanted to show that we pulled together a robust team. And to Chris's point, when pulling all of these different ideas together, we were able to hear from the people that actually do the work day to day, what works and what doesn't work. So large team. I'm probably in the back there somewhere, but yes. So in slide 6. Just a quick review of kind of the whole person, whole picture idea, which is a bit different than what we've seen over the years. This is what we're really preaching for our eligibility workers, is to make decisions based on the information that we have, that people are getting the right care at the right time in the right setting. Where we start with earlier and streamlined documentation. To Chris's point, a application could be somebody writing their name, signing and dating. However, it does not provide any of the financial information or medical information. So how can we help families before they get to that point of submitting, that they have all of that documentation that we already know that we need ready to go, so they're not put in the queue and touched and come back. I think the other piece we really talked about was going from a task-based model to a case-based model. So we hear from families and individuals and facilities that they don't know who to talk to at the department to ask about their Medicaid eligibility. There's not a worker assigned to a person. So we really explored that with our Bureau of Family Assistance workers, and I think we've seen that change really positive, where families know that they're assigned to a specific person in the department if they have a question about their Medicaid eligibility, both for financial eligibility and medical eligibility. We also looked at, the structured person-centered judgment. We're taking the philosophy that people are applying on good faith, and not everyone's applying to be fraudulent with the system. So we brought up some really key ideas, looking at, the Medicaid actual eligibility rules, not kind of department lore or history. Boiled it right down to what the CMS tell us we have to do and what is in our rules that we have to do to determine eligibility. And giving that to the eligibility workers, so they're not spinning their wheels on looking at a $200 transaction 4 years ago. That was a birthday gift to a grandkid. So really using those real-time scenarios. And then I'll hand it to Dave.
Good morning. My name is Dave Hobson. I'm the Director of Project Management for the department. And I'm on slide 7, Project Goals and Deliverables, for your reference. About a year ago, our Make Eligibility project team was given 5 major goals and about 24 deliverables. All of them focus on making long-care eligibility easier to navigate. A big part of our work is creating better financial and medical eligibility materials that support our internal staff, help our external partners, and provide plain language information that's easier for clients to understand. We're also putting a strong emphasis on project professional development within the long-term care team. That includes accelerated training, improving the work environment, and strengthening the connection between the financial and medical parts of the application process. And finally, we're introducing significant improvements to the New Heights system, which manages client applications. These enhancements are designed to make the process smoother to give our staff better tools to do their work. On the next slide, we'll talk about key accomplishments. So far, the impact of our project has been very positive. By combining our new processes and support from the public consulting group, we've reduced the long-term care application backlog by almost 50%. Now we're reviewing client application documentation at around 47 days into the process instead of at 120 days that we're seeing earlier. Staff are feeling more confident in their work thanks to clearer eligibility guidance, both for our internal team and for the partners who help clients through the process. And in terms of short-term wins, within the long-term care project, we have expanded the use of electronic asset verification reviews, which lets us rely less on paper statements. We're moving those electronic account reviews earlier in the workflow so that we can get the staff key information earlier to make those decisions. We've been streamlining the 5-year look-back requirement by reducing the number of required financial statements per account from 60 statements to 16. This means asking for monthly statements for the past year, plus one consistent statement for each of the prior 4 years. And we've clarified, as Chris said, what reasonable compatibility means for both resources and income, so staff have a clear understanding and guidance to follow.
On slide 10, we talk a little bit about the medical eligibility assessment, or the MEA. I think some of you are familiar with that process. So we took time to look at our annual review process for home and community-based care to make it easier and faster and focused on the needs of the people that we serve. So the new approach, which we did get approval from CMS to use, would be something using information that we already have at our fingertips at the state. Our prior process was the initial determination and the redetermination were the same form. It was about 14 pages of a medical assessment where you were determined eligible, and then the next year you have to go through the same process. So what we convened a stakeholder group, met several times over the past 18 months, and developed a case management attestation process. So if once somebody is initially determined medically eligible, every year the case management agencies or the case manager can attest that this person still needs choices for independence waiver services in the community, or we can still do a full assessment on them if they feel like their status has improved. So it not only saves time, but it also saves money as far as needing a contractor to do all of those medical assessments for us. So people will have a speedier medical determination on their redeterminations and not go through the rigorous process of being determined every year throughout the 17-page assessment that we have currently. So
For your planning, I got to give you just about 5-6
Yep.
more minutes.
I'm done on my slide.
I think what Melissa said too, just to highlight that, is that we used our existing utilization data. If somebody who's been on the CFI program for 3 years and they get 40 hours of personal care service, we know they still need that service. They're still eligible. So instead of duplicating efforts and really hearing from our provider partners was critical in that. I think the next slide 12, this just highlights what the commissioner stated. We had legislative support. I think we had to, House Bill 2, Chapter 141, required that we have to provide 6-month backlog reports, which the most recent one we did submit. It is in the pile on your table, but also contract with a contractor to help us with the backlog. And this is really important because the changes we're making are system changes, they're policy changes, it's culture change. It takes time, and we need help to help us with the backlog, which staff are doing a great job, but we also need help so we can make the sustainable changes while we're bringing down the backlog. It has been extremely successful, which has been great. And also they, as part of this contract, was to provide us with a review of our processes, and that is also included in your packet. And I think the proof is in the pudding on the next slide that the commissioner mentioned. Since January, we have seen a 47% reduction in backlog. I am super proud of our staff. This is extremely hard work, and seeing the fruit of their labors is significant. But at the same time, it's important, if you can see on the left-hand side, our number of applications are still going up. So we're taking care of the backlog, yet as a significant number of applications are still coming up. So between our process changes that Dave and Melissa mentioned, between having PCG helping us, and our own internal strategies, we're making a dent, and it's really significant. PCG, on the next slide, slide 14, in addition to providing us support to review applications, they cannot make determinations, but what they do is they can review all the documentation and say to our staff, this looks really good, and we'll do a quick review to make sure people are eligible. They're also in 40 different nursing facilities across the state, and they're providing support to families, to the staff of the nursing facilities when they say, what else do we need for this? Where are we with this process? And the nursing facilities have found this extremely helpful. They have a point of contact that is on site in their office. So I think we are going to move to questions if you have any. In the time, you have a robust slide deck. Please reach out if there's anything we didn't cover.
Okay, Representative Weber.
I just, a quick thing that I lost while I was trying to listen and type at the same time. Explain PCG to me.
Public Consulting Group, that
Okay.
was the contractor.
Okay.
Representative Lamontagne.
Thank you, Mr. Chair. And it's great to see you made so much progress about this. But just a quick question. Are there any federal CMS prohibitions against having presumptive eligibility? And
We do
would you support that?
We do have presumptive eligibility. We are working on presumptive eligibility. It is part of our 1115 waiver. It's been stalled. However, you still have to go through and do a full eligibility assessment. And because there's very limited services that you can provide under the presumptive eligibility. So while we are still looking at that with CMS, it's kind of in their hands right now. We really feel strengthening this system and making initial determinations faster is better for the family, it's better for our staff, and it's better for the provider.
Thank you so much. Now the chair recognizes whoever's next.
Hi there. My
Hi.
name is Hannah Sharp. I'm the Patient Safety Officer for Elliott Health System, and I represent the Elliott as a member of the New Hampshire Healthcare Quality and Patient Safety Commission, and I'm just finishing up my 2-year rotation as the commission's chair.
And good morning. I'm Chris Herring, Vice President for Quality Improvement at the Foundation for Healthy Communities, and I'm the administrator for the New Hampshire Healthcare Quality and Patient Safety Commission. If I may respectfully request a correction on the agenda, we are going to be presenting today the 2026 report and not the 2025 report. And you have a copy of that in front of you. Thank you.
We'll make the update. Thank you.
Thank you. So originally established in 2005, the New Hampshire Healthcare Quality and Patient Safety Commission exists to reduce medical harm statewide by creating a confidential and non-punitive forum where hospitals and ambulatory surgery centers can openly share adverse events, lessons learned, and prevention strategies. So in this respect, the commission functions as a statewide safety infrastructure by strengthening quality oversight accelerating learning across organizations, and it supports alignment with federal and state regulatory requirements. Participation in this commission is voluntary, and it includes all 26 acute care hospitals, 4 specialty hospitals, including our acute rehabilitation and psychiatric hospitals, and 15 ambulatory surgery centers, a designee of the Commissioner of DHHS, and 3 at-large public members representing the voice of the patient. The commission meets in person 5 times a year with a virtual option for extenuating circumstances. Last year, attendance was high at each meeting with approximately 30 to 35 members participating. There are 4 guiding principles that focus the commission's work and agendas, and they include high reliability and system safety, which includes standardizing processes, improving systems, and detecting risks before harm occurs. Just culture and workforce accountability to ensure that staff are treated fairly during event investigations and that system failures are distinguished from reckless behavior. Evidence-based best practices to promote adoption of proven interventions to reduce harm, especially in high-risk areas, and patient voice and safety for all, which includes public members who ensure patient perspectives, shape agendas, and improvement priorities. The commission encourages organizations to incorporate patient input into root cause analysis and care redesign.
So at each commission meeting, there was review and discussion of the most recent serious reportable events data. We call them SREs, which is provided quarterly by New Hampshire DHHS. And the good news is that New Hampshire experienced a decrease in adverse events in the calendar year 2025 compared to calendar year 2024, with 129 events reported, and that's compared to 142 events the prior year. So our report, which I believe you all should have a copy of, describes the areas of focus for the commission this past year, and we just want to share a few highlights from that. So first, reducing falls and falls with injury. In 2025, falls that led to death or serious injury were the highest reportable adverse event statewide. So members shared some data-driven strategies, process improvement cycles, electronic medical record optimization, and new roles such as mobility technicians to help keep patients safe. Another activity was around regulatory readiness. So each of the organizations is surveyed routinely by accrediting agencies, either CMS or an agency on behalf of CMS. And so the members shared lessons learned on infection control, equipment maintenance, EMTALA, restraint documentation, and low volume provider verification. The commission focused on public health coordination. And so we received regular updates from the state epidemiologist on respiratory illness trends, measles resurgence, evolving CDC immunization guidance. And then next, with CMS requiring patient safety organization participation for certain federal measures, members discussed the benefits, some limitations, and data sharing experience in regards to certain patient safety organizations. Another area of focus was chemical restraints and patient rights. The commission reviewed CMS requirements for restraint use, emphasizing de-escalation, patient engagement, monitoring, and documentation practices. And around serious reportable events, commission members spent some time detailing the review of the National Quality Forum's 2025 updates, including 5 new serious reportable event categories and some other revised reporting criteria to ensure consistent reporting practices statewide. So these are just some highlights from our more detailed report that you have. And as the commission enters its 22nd year, it remains grateful to the New Hampshire legislature for this unique body The commission delivers statewide value without adding regulatory burden, and its confidential structure really allows hospitals to learn from each other and each other's adverse events, and that's something that's not possible through public reporting or traditional oversight. So it accelerates harm reduction efforts, and it strengthens compliance with federal programs and improves patient safety across New Hampshire hospitals and ambulatory surgical centers. So thanks to you. And thank you for this opportunity, and we're happy to take any questions as time permits.
Any questions? Representative Mooney.
Thank you very much, Mr. Chairman. Thank you both for being here and this careful work. As for your goal here of public health updates and information sharing, is that where you get into viral situations, bacterial? I mean, it's well known that a lot of times people enter hospitals and they contract certain things. That is certainly of a concern when it comes to public safety, whether it be COVID, whether it be pneumonia, whether it be a common cold or the flu. Is that included in that particular section, or is that different, or do you not cover that?
Somewhat. And so our state epidemiologist will give us sort of cutting edge insights into what's happening globally, nationally, locally. And so that we've got some key sort of information to bring back to our organizations. Sometimes there is some dialogue around kind of what we're seeing and then what best practices are to prevent hospital-acquired infections, whether it's viral, bacterial, et cetera. So we do get into some pretty robust conversations, not just around kind of the public health updates, but then also what we're doing sort of in response so that we can align and make sure that we're sharing best practices.
Further questions? Senator Prentice.
Thank you. Thank you, Chair Pearson, and thank you both for providing this report today. So during this past legislative session, Senator Rochford and I sit on Health and Human Services. There was a bill that came forward on clot prevention, venous thrombosis prevention, and wanting to put mandate statewide screening mechanisms. And, you know, what I know from having worked in hospitals is that most, if I would think, I mean, the ones I've been involved in, they all have, you know, a pathway for this. But there was a specific case that got missed that led to, you know, a postpartum death. And it, you know, it was discussed in public, so I'm not telling anything that or saying anything that I shouldn't. But during, we put this on hold and spoke with the Hospital Association, was there to testify to try to make the cross connection because Ben Bradley had raised this particular, your group to us and saying, this may be the right place to review cases like this and make recommendations. And I've gone through and it might just be too soon and I don't see it in here, but how do we navigate this so that we can get this before you all?
Sure. Thank you very much for that question. And I have spoken to Ben about this. So I'm well versed, I think, to speak on this. So as part of our process during the course of the year, we're reviewing adverse events that occur for patients. We also look at new quality measures that are going to be implemented for organizations during the various quality programs. For example, CMS Hospital Quality Improvement Program that our hospitals participate. And there are going to be new measures that are going to be coming down the pike, and one of them includes VTE prophylaxis. So that'll be part of our review in this upcoming year. It's not an area that we discussed in this past year, but that is something that we will have as part of our agenda and will be reflected in next year's report.
Thank you so much.
You're welcome.
Further questions? Seeing none, thank you.
Thank you.
Thank you.
And now the chair recognizes Doreen Shockley, Manager, Bureau of Licensing and Certification of New Hampshire Department of Health and Human Services, who has up until 11:45.
I can do that. Thank you. Good morning, Chairman Pearson, committee members. It's good to see you again. As was mentioned, my name is Doreen Shockley. I am the manager of the Bureau of Licensing and Certification at the Department of Health and Human Services. I've highlighted the items on what I was originally going to say in 20 minutes. I've highlighted to bring to your attention the package that you just received. So that is a copy of the 2025 adverse event reporting. Pursuant to RSA 151 and consistent with the National Quality Forum, hospitals or ambulatory surgical centers licensed are required to report the occurrence of any adverse health care event, otherwise referred to as a serious reportable event. They are considered to be preventable, and as was discussed with the folks, Chris, right before me, they focus a lot on the details of these as well. The 2025, and they did also mention that we have seen a decrease from 2024 from 142 to 129 in 2025. Pages 7 through 9 summarize the 3 most frequently reported events, which include falls, care management involving stage 3, stage 4, or unstageable pressure injuries, and surgical events. As required, the Bureau conducted quarterly 10% sample audits of the corrective action plans submitted by hospitals and ambulatory surgical centers. The facilities have provided evidence of action plans implemented, including staff education, auditing, and updated policies. All facilities included in the audits were found to have implemented their corrective action plans. We continue to share the information with our colleagues at New Hampshire Healthcare Quality and Patient Safety Commission, and we appreciate the collaboration that we have. I'd also like to note that the NQF issued updated reporting requirements in early 2026, which went into effect February 25th of 2026. So next year, you'll see our reporting is very different to come in line with the new requirements. Thank you. Do you have any questions?
Can you talk for 7 more minutes?
I prefer not to.
That would be an averse.
Yes.
Okay, I have a question just to, I think I know how many hospitals we have. How many ambulatory surgical centers do we have? It may be in the report, but I haven't read it.
I don't, it's in my notes, but it's not in there. You know,
Anybody want to guess?
I know it's in
thought
my
I heard
notes.
Somebody say 15 earlier.
15.
No. There's 61 total facilities.
Could you come up to the mic, please? The senator has old ears.
She was the only one I could hear all day, though.
This is free, so streaming people can't hear you unless they're near.
I can't find it in my notes.
Hi.
I know I have it.
Thank you for inviting me back.
Welcome back.
Yes, so there are 15 ambulatory surgery centers that are actively participating in the Quality Commission. Those tend to be the larger ambulatory surgery centers, and then there are some smaller centers that really don't have the bandwidth to participate. But and I'm looking for the exact number, but it is a 61
Thank you.
from what I can see, and that's in the adverse event report, that there are 61 licensed ambulatory surgery centers.
And only 15 participate?
15 actively participate. There are more than that get the meeting agenda and the meeting minutes.
Oh, participate in your
Coming to-
meetings?
Correct.
By
Coming
law,
in
they have to
person our-
participate in the reports?
Correct.
Okay, good, thank you.
Absolutely.
Mr. Chairman, press order.
Yeah, they're distracted, yeah, okay. Representative Weber.
Just for clarity for the minutes, I was told to correct the last presentation to be the 2026 New Hampshire Healthcare Quality and Patient Safety Commission report. And it cited the same numbers that you just talked to about being from the 2025 report, the 142 to 129. So I'm a little confused as to which year we're talking
So
about.
the adverse events, thank you, Representative Weber, the adverse event report is for 2025. I believe their report was for 2026, including 2025 adverse events.
So we're just including the numbers before in the updated report. Is
That's
that correct?
correct. Our
Okay, thank
year
you.
goes August through July, and so our 2026 report includes the 2025 data.
Okay, thank you very much. I just wanted to be sure I hadn't gotten off track there.
Any other questions? Thank you, Ms. Shockley.
Thank you very much. Have a
And
great
everyone
day.
for participating. Just a reminder, if you are interested either in commentary on what a subcommittee to help the department on Medicaid fraud would look like, or if you want to volunteer for it, or if you know somebody you want to volunteer that person for, please shoot me an email in the next week or so. And with that, I see nothing further. We are finished.
Next meeting?
And the next meeting will be September, whatever the fourth Friday of September is. Thank you.